Emergency surgical management of inflammatory bowel disease. A question and answer session on acute care for inflammatory bowel disease. Welcome to our podcast dedicated to the emergency surgical management of inflammatory bowel disease. In this session, we present 100 resident-level questions and answers, each designed to provide clarity and practical insight for clinicians facing urgent surgical decisions. Pause the video after each question to attempt answer. Let's begin. Section 1. Indications for emergency surgery and preoperative assessment. Questions 1-20. Question. What are the absolute indications for emergency surgery in ulcerative colitis? Answer. The absolute indications are toxic megacolon that does not respond to medical therapy, colonic perforation, uncontrolled life-threatening colonic hemorrhage, and fulminant colitis with clinical deterioration despite maximal medical therapy. Question. What are the common emergency surgical indications in Crohn's disease? Answer. Common indications include acute bowel obstruction caused by a fibrostenotic stricture, intra-abdominal abscess that cannot be drained percutaneously or fails to drain, free perforation, massive hemorrhage, and fistula with associated complications such as obstruction or abscess. Question. A patient with ulcerative colitis has 10 bloody stools per day, abdominal distension, and a fever of 39 degrees Celsius. An X-ray shows a transverse colon diameter of 7 centimeters. What is the diagnosis and the most critical initial step? Answer. The diagnosis is toxic megacolon, and the most critical initial step is immediate surgical consultation. Question. What preoperative laboratory tests are essential before taking a patient with inflammatory bowel disease for emergency surgery? Answer. The essential tests include a complete blood count, a comprehensive metabolic panel with focus on albumin and electrolytes, coagulation studies, C-reactive protein or erythrocyte sedimentation rate, liver function tests, and a type N screen or cross-match. Question. Why is the albumin level an important prognostic marker? Answer. A low albumin level reflects severe malnutrition and chronic inflammation and is a strong predictor of increased post-operative complications, including anastomotic leak and infection. Question. What is the significance of a high lactate level in a patient experiencing a flare of inflammatory bowel disease? Answer. A high lactate level suggests tissue hypoperfusion and may indicate ischemic bowel, gangrene, or septic shock. It is a red flag for a catastrophic abdominal process. Question. What key elements of the patient's history must you convey to the surgeon? Answer. It is important to convey the patient's current medications, especially biologics and steroids, history of prior abdominal surgeries, nutritional status, and the duration and severity of current symptoms. Question. A patient on high-dose prednisone presents with a perforation. What endocrine concern do you have intraoperatively and postoperatively? Answer. The major concern is adrenal insufficiency. The patient will require stress-dose steroids, such as intravenous hydrocortisone 100 mg every 8 hours during the perioperative period. Question. What is the role of preoperative antibiotics in emergency surgery for inflammatory bowel disease? Answer. Broad-spectrum intravenous antibiotics covering gram-negative and anaerobic bacteria, such as piperacillin tazobactam or carbapenem, should be administered within 60 minutes before the incision to reduce surgical site infections. Question. How does recent use of anti-tumor necrosis factor therapy affect surgical risk? Answer. Recent use is associated with an increased risk of postoperative infectious complications, but is not an absolute contraindication to emergency surgery. The surgical team must be aware. Question. What is the primary goal of emergency surgery for toxic megacolon? Answer. The primary goal is to remove the diseased, dilated colon to prevent perforation and control sepsis, rather than to provide a definitive cure. Question. What is the primary goal of emergency surgery for a Crohn's disease obstruction? Answer. The goal is to relieve the obstruction while preserving as much bowel length as possible. This may involve resection or stricturoplasty. Question. What preoperative imaging is most valuable for the surgeon in Crohn's disease? Answer. A computed tomography scan of the abdomen and pelvis with intravenous and oral contrast is most valuable, as it shows the location of strictures, fistulae, abscesses, and the condition of the uninvolved bowel. Question. When should you request an urgent surgical consult for a perianal abscess in a patient with Crohn's disease? Answer. An urgent surgical consult should be requested immediately, as a perianal abscess is a surgical emergency requiring incision and drainage. Delay can result in complex fistulas or Fournier's gangrene. Question. What is the concern when a patient exhibits a guarding or rigid abdomen on examination? Answer. This finding indicates peritonitis, which is a surgical emergency suggesting perforation or ischemic bowel. Question. What is the role of nasogastric tube placement preoperatively? Answer. For bowel obstruction or significant ileus, nasogastric tube decompression reduces aspiration risk, relieves vomiting, and can make the surgery safer. Question. Why is aggressive fluid resuscitation critical before emergency surgery for inflammatory bowel disease? Answer. Patients are often severely dehydrated from diarrhea, vomiting, and third spacing, and may be septic. Adequate resuscitation optimizes perfusion and reduces the risk of postoperative acute kidney injury. Question. What is an inflammatory mass on a computed tomography scan, and what are the surgical options? Answer. An inflammatory mass may be a phlegmon or an abscess. Options include percutaneous drainage if accessible, or resection. Surgery on a phlegmon can be technically difficult. Question. When is surgery indicated for an enterovesical fistula? Answer. Surgery is rarely an emergency for enterovesical fistula. Elective surgery is indicated for persistent symptoms, such as recurrent urinary tract infections and pneumaturia, that affect quality of life. Emergency surgery is indicated only if there is an associated abscess or obstruction. Question. What is the key decision-making principle in emergency surgery for Crohn's disease? Answer. Bowel preservation is paramount. The aim is to resolve the immediate life-threatening complication using the most conservative procedure possible to avoid short bowel syndrome. Section 2. Surgical procedures and intraoperative decisions. Questions 21-50. Question. What is the procedure of choice for emergency surgery for toxic megacolon or fulminant ulcerative colitis? Answer. The procedure of choice is subtotal or total colectomy with endoleostomy and creation of a Hartmann's pouch, which avoids a high-risk anastomosis in a critically ill, malnourished, and immunosuppressed patient. Question. Why is an ileorectal anastomosis or ileal pouch anal anastomosis not created in the emergency setting? Answer. These procedures are not performed in emergency settings because the patient is too unstable, tissues are inflamed and friable, and the risk of anastomotic leak is unacceptably high. These procedures are performed electively at a later stage. Question. What is a Hartmann's pouch? Answer. Hartmann's pouch is the closed-off rectal stump left in the pelvis after subtotal colectomy. It may later be reconnected to the ileum or used to create a pouch. Question. What are the two main surgical options for a fibrostenotic Crohn's stricture causing obstruction? Answer. The two main options are resection of the diseased segment with primary anastomosis or stricturoplasty, which preserves the bowel. Question. Describe a Heine-Kamikalich stricturoplasty. Answer. A Heine-Kamikalich stricturoplasty involves making a longitudinal incision across the stricture, followed by transverse closure, effectively widening the lumen. It is used for short strictures less than 10 centimeters. Question. When is stricturoplasty contraindicated? Answer. Stricturoplasty is contraindicated for perforation, phlegmon, fistula at the stricture site, multiple strictures in a short segment, or suspicion of malignancy. Question. How do you manage a free perforation in Crohn's disease? Answer. Management involves resection of the perforated segment. The decision between primary anastomosis and creating an ostomy depends on patient stability, degree of peritoneal contamination, and nutritional status. Question. What factors favor creating an ostomy over a primary anastomosis in emergency surgery for Crohn's disease? Answer. Factors favoring an ostomy include hemodynamic instability, high-dose steroids, malnutrition with albumin less than 3 grams per deciliter, significant peritoneal contamination, and a tenuous blood supply at the anastomosis. Question. What is the surgical approach to an intra-abdominal abscess that has failed percutaneous drainage? Answer. The approach is laparotomy, drainage of the abscess, and resection of the diseased bowel segment that is the source of the abscess. Question. What is the primary surgical principle when dealing with a fistula caused by Crohn's disease? Answer. The primary principle is to resect the diseased segment of bowel from which the fistula originates. Closing the fistula without addressing the source will lead to recurrence. Question. A patient has a terminal ileal stricture with an associated enteroenteric fistula to a healthy jejunal loop. What is the procedure? Answer. The diseased terminal ileum is resected. The healthy jejunal loop involved in the fistula may only require simple closure if otherwise normal. Question: what is the surgical management of a complex perianal fistula with an abscess? Answer: management includes examination under anesthesia, incision and drainage of the abscess, and placement of a non-cutting seton to drain infection and prevent recurrent abscess formation. Question: why is a non-cutting seton used? Answer: a non-cutting seton maintains drainage and allows for maturation of the fistula tract, facilitating a later, definitive elective procedure when the disease is quiescent. Question: when is proctectomy indicated in the emergency setting? Answer: proctectomy is rarely indicated in emergencies. It may be necessary for uncontrolled perineal sepsis from complex fistulizing disease not controlled with drainage and setons, or for hemorrhage from rectal disease. Question: what is the risk of operating on a patient with a large abdominal phlegmon? Answer: the risk of inadvertent enterotomies is high due to dense, vascular adhesions and distorted anatomy, necessitating an experienced surgeon. Question: what is the advantage of a laparoscopic approach in emergency surgery for inflammatory bowel disease? Answer: if feasible, laparoscopy offers smaller incisions, less pain, and faster recovery, but is often contraindicated in severe inflammation, distended bowel, or hemodynamic instability. Question: what is the most critical step after a colectomy for toxic megacolon? Answer: meticulous closure of the rectal stump or Hartmann's pouch is critical, as a leaking stump can cause devastating pelvic sepsis. Question: how do you manage the rectal stump post-colectomy to prevent stump leak? Answer: a well-vascularized, tension-free closure is essential. Some surgeons place a drain in the pelvis. Post-operative management includes keeping the nasogastric tube until ileus resolves. Question: what is the surgical finding of creeping fat in Crohn's disease? Answer: creeping fat refers to hypertrophied mesenteric fat that extends over the serosal surface of the inflamed bowel. It is a classic finding that makes dissection and anastomosis more challenging. Question: why is massive mesenteric bleeding a risk in surgery for Crohn's disease? Answer: the mesentery is often thickened, foreshortened, and highly vascular. Ligation of mesenteric vessels must be done carefully to avoid retraction and life-threatening hemorrhage. Question: what is the role of intraoperative enteroscopy? Answer: intraoperative enteroscopy is used to identify subtle strictures or lesions not palpable from the serosal surface, ensuring all obstructive points are addressed. Question: a patient has multiple strictures throughout the small bowel. What is the surgical strategy? Answer: the strategy is a skip resection of the most severely diseased segments causing obstruction, combined with stricturoplasties for shorter strictures to preserve as much bowel length as possible. Question: when is a diverting loop ileostomy used? Answer: a diverting loop ileostomy is used to protect a distal anastomosis at high risk for leak or to divert the fecal stream away from a perineal wound to allow healing. It is a temporary, reversible ostomy. Question: what is the difference between an endoileostomy and a loop ileostomy? Answer: an endoileostomy is created from the transected end of the ileum and may be permanent or temporary. A loop ileostomy is created by bringing a loop of ileum to the skin, opening the antimesenteric border, and is almost always temporary. Question: what is the most common emergency surgery for Crohn's disease? Answer: the most common emergency surgery is resection of the terminal ileum for obstruction or fistula. Question: how do you manage a duodenal Crohn's stricture? Answer: stricturoplasty is preferred, such as Heineke-Mikulich stricturoplasty or a side-to-side gastrojejunostomy to bypass the stricture, avoiding pancreaticoduodenectomy. Question: what is the Kono-S anastomosis? Answer: the Kono-S anastomosis is a novel antimesenteric, functional end-to-end anastomosis supported by an extramural buttress. It is designed to reduce recurrence at the anastomotic site, but is primarily used in elective settings. Question: why should the mesenteric defect be closed after a small bowel resection? Answer: closing the mesenteric defect prevents an internal hernia, which can cause future small bowel obstruction. Question: what is the significance of finding fat wrapping intraoperatively? Answer: fat wrapping is a hallmark of active Crohn's disease and helps the surgeon identify the diseased segment that requires resection or stricturoplasty. Question: when is a second-look laparotomy indicated? Answer: a second-look laparotomy is indicated in damage control surgery for profound sepsis or when bowel viability is questionable. The abdomen is temporarily closed, and the patient returns to the operating room in 24 to 48 hours for re-exploration. Section 3. Postoperative management and complications. Questions 51-80. Question. What is the most feared early complication after bowel resection and anastomosis? Answer. The most feared complication is an anastomotic leak. Question. What are the clinical signs of an anastomotic leak? Answer. Clinical signs include fever, tachycardia, peritonitis, elevated white blood cell count, and increased drain output if a drain is present, which may be feculent. Question. How is an anastomotic leak diagnosed? Answer. Diagnosis is made using a computed tomography scan with oral contrast. Extravasation of contrast is diagnostic. A low threshold for re-exploration is required if the patient is unstable. Question. What is the management of an anastomotic leak? Answer. Management consists of emergent reoperation, usually taking down the anastomosis, bringing out the proximal end as an endostomy, and managing the distal end as either a mucus fistula or oversewing it in a Hartmann's procedure. Question. Why are patients with inflammatory bowel disease at high risk for venous thromboembolism postoperatively? Answer. Inflammatory bowel disease is a prothrombotic state. Surgery adds further risk. Aggressive venous thromboembolism prophylaxis with subcutaneous heparin or low molecular weight heparin and sequential compression devices is mandatory. Question. What is the most common cause of early small bowel obstruction after surgery for inflammatory bowel disease? Answer. The most common cause is postoperative adhesions, but an internal hernia through an unclosed mesenteric defect must also be considered. Question. A patient post-colectomy has high ostomy output greater than 1.5 liters daily. What is the concern? Answer. The concern is high output ileostomy, which leads to dehydration and electrolyte losses, including sodium, potassium, and magnesium. Question. How do you manage a high output ileostomy? Answer. Management involves intravenous fluid resuscitation, electrolyte replacement, nothing by mouth, initiation of antisecretory agents such as loperamide, proton pump inhibitors, and somatostatin analogs, and gradual advancement of a diet low in simple sugars. Question. What is postoperative ileus and how is it managed? Answer. Postoperative ileus is a temporary disruption of normal bowel motility. Management includes nothing by mouth, placement of a nasogastric tube if distended or vomiting, and supportive care until flatus or bowel function returns. Question. What is the difference between ileus and early postoperative obstruction? Answer. Ileus is a generalized dysmotility, while obstruction is a mechanical blockage suggested by crampy pain, earlier return of symptoms, and a transition point on a computed tomography scan. Question. What is a stoma-related complication to check for at the bedside? Answer. Stoma ischemia should be checked for. A healthy stoma is beefy red and moist, while a dark, purple, or black stoma indicates ischemia and requires immediate surgical evaluation. Question. What is the management of a superficial surgical site infection? Answer. The wound should be opened at the bedside, packed, and allowed to heal by secondary intention. Question. What is an enterocutaneous fistula and when should it be suspected postoperatively? Answer. An enterocutaneous fistula is an abnormal connection between the bowel and the skin. It should be suspected if enteric drainage comes from the wound or a drain more than 5 to 7 days after surgery. Question. What is the initial management of a postoperative enterocutaneous fistula? Answer. Management includes nothing by mouth, total parenteral nutrition, control of sepsis with antibiotics and drainage, and wound care. Most will close with non-operative management if there is no distal obstruction. Question. Why is nutrition critical in the postoperative period? Answer. Malnutrition impairs wound healing and immune function, increasing the risk of anastomotic leak and infection. Early enteral nutrition is preferred when possible. Question. When should biologic therapy be restarted after emergency surgery? Answer. Biologic therapy is typically not restarted for at least 2 to 4 weeks postoperatively, once there is evidence of good wound healing and no signs of ongoing infection. This is a decision for the gastroenterologist and surgeon. Question. A patient develops sudden scrotal swelling and pain postoperatively. What is your concern? Answer. This could be a retroperitoneal hematoma tracking down, or more seriously, Fournier's gangrene, which is a surgical emergency. Question. What is short bowel syndrome and who is at risk? Answer. Short bowel syndrome is malabsorption and diarrhea resulting from extensive small bowel resection. Patients with more than 200 centimeters of resected bowel or those with less than 200 centimeters of remaining small bowel are at high risk. Question: what is dumping syndrome and when can it occur after surgery for inflammatory bowel disease? Answer: dumping syndrome is rapid gastric emptying causing nausea, cramping, diarrhea, and vasomotor symptoms such as sweating and dizziness. It can occur after gastrectomy or, rarely, after extensive small bowel resection. Question: what is the most common long-term complication after ileal resection for Crohn's disease? Answer: the most common long-term complication is disease recurrence, most commonly at the neoterminal ileum or anastomotic site. Question: how is a pelvic abscess diagnosed post-colectomy? Answer: diagnosis is made by computed tomography scan, and often requires CT-guided percutaneous drainage. Question: what is a steroid-sparing protocol post-operatively? Answer: a steroid-sparing protocol is a slow, graded taper of corticosteroids to prevent adrenal insufficiency while avoiding high doses that impair healing. Question: what is the role of an abdominal binder after surgery? Answer: an abdominal binder can provide support and improve comfort, especially in patients with large incisions or ostomies. Question: when is a patient with a new ileostomy ready for discharge? Answer: the patient is ready for discharge when afebrile, tolerating a diet, having consistent ostomy output, and most importantly, is independent in ostomy care. Question: what is a peristomal hernia? Answer: a peristomal hernia is a hernia through the abdominal wall defect created for the stoma. It is a late complication, but can present early with pain, obstruction, or difficulty with appliance fitting. Section 4. Special scenarios and controversies. Question 76-100. Question: a pregnant patient with ulcerative colitis at 28 weeks develops toxic megacolon. What is the management? Answer: management involves a multidisciplinary team, including surgery, obstetrics, and gastroenterology. The mother's life is the priority. Emergency colectomy is indicated, and the fetus is monitored. A cesarean section may be performed concurrently if the fetus is viable. Question: how does surgery for indeterminate colitis differ? Answer: surgery is similar to ulcerative colitis. The emergency procedure is subtotal colectomy with endoleostomy. The pathology of the resected specimen may later provide a definitive diagnosis. Question: what is the risk of cancer in the rectal stump after subtotal colectomy for ulcerative colitis? Answer: the risk of cancer remains. The patient needs ongoing surveillance with proctoscopy every 1 to 2 years if the stump is retained, or must proceed with completion proctectomy. Question: when is emergency surgery indicated for inflammatory bowel disease in a pediatric patient? Answer: indications are the same as adults. Fulminant colitis, toxic megacolon, perforation, obstruction, and massive hemorrhage. Principles of bowel preservation in Crohn's disease are even more critical in children. Question: what is the damage control approach in a critically ill patient with inflammatory bowel disease? Answer: damage control involves a staged approach. First, control contamination by resecting bowel and creating ostomy, leaving the abdomen open. Next, resuscitate in the intensive care unit. Then, perform definitive reconstruction once stable. Question: what is the role of ureteral stents preoperatively? Answer: for complex, reoperative surgery or a large inflammatory mass, preoperative placement of ureteral stents can help identify and protect the ureters from injury. Question: how do you manage a patient with an acute severe flare after an ileal pouch anal anastomosis? Answer: rule out pouchitis, which is treated with antibiotics, and cophitis, which is treated with mesalamine or steroid suppositories. Surgery is reserved for refractory cases or complications such as pouch leak or fistula. Question: what is a pouch vaginal fistula and how is it managed? Answer: a pouch vaginal fistula is a connection between the ileal pouch and the vagina. It requires examination under anesthesia, seton placement, and often revisional pouch surgery. Question: when is a diverting ileostomy indicated for pouch-related sepsis? Answer: for a leaking pouch or pelvic sepsis. The initial step is often diversion with a loop ileostomy and pouch drainage, with the hope of salvaging the pouch later. Question: what is the most common reason for pouch failure requiring excision? Answer: chronic pouchitis, fistula, anastomotic stricture, or pelvic sepsis are the most common reasons. Question: how does primary sclerosing cholangitis affect surgical planning in ulcerative colitis? Answer: Patients with ulcerative colitis and primary sclerosing cholangitis have a very high risk of colon cancer, which may lower the threshold for elective colectomy. Question: what is the risk of rectal cancer after an ileorectal anastomosis for Crohn's colitis? Answer: the risk is elevated compared to the general population but lower than in ulcerative colitis. Ongoing annual surveillance of the rectum is required. Question: how do you handle a patient with an incidental finding of dysplasia on a colectomy specimen done for emergency? Answer: this must be communicated to the patient and documented, reinforcing the need for eventual completion proctectomy if the patient has ulcerative colitis. Question: what is the Turnbull cutate procedure? Answer: the Turnbull cutate procedure is a delayed colonal anastomosis, sometimes used in complex rectal surgery. It is not an emergency procedure. Question: what is the role of enhanced recovery after surgery protocols in emergency surgery for inflammatory bowel disease? Answer: while full implementation is challenging, principles such as early enteral feeding, multimodal analgesia to reduce opioids, and early mobilization should be applied to improve outcomes. Question: a patient with a remote history of colectomy for ulcerative colitis presents with bloody discharge from the rectum. What is the concern? Answer: the concern is hemorrhage from the Hartmann's pouch stump or, rarely, carcinoma in the stump. This requires proctoscopy. Question: what is a blowhole procedure? Answer: the blowhole procedure is a historical and rarely used operation for toxic megacolon involving a loop ileostomy and a decompressing colostomy. It has been largely replaced by subtotal colectomy. Question: why is it important to send the entire surgical specimen to pathology? Answer: it is important to confirm the diagnosis, assess the margins, and rule out unsuspected dysplasia or cancer. Question: what is the key to managing a postoperative enterocutaneous fistula? Answer: the key is control of the fistula. 5. Nutrition, fluid and electrolytes, sepsis, skin care, and defining the anatomy. Question: when is a fistulogram helpful? Answer: a fistulogram is useful to define the anatomy of an enterocutaneous fistula, its origin, length, and presence of distal obstruction, which guides management. Question: what is the most common cause of death after emergency colectomy for toxic megacolon? Answer: sepsis and multi-organ failure are the most common causes. Question: what is the role of the white blood cell scan in the postoperative period? Answer: it can help localize a source of occult sepsis, such as an intra-abdominal abscess, when the computed tomography scan is equivocal. Question: how do you manage a postoperative pelvic abscess that is not accessible percutaneously? Answer: management is by surgical re-exploration, either transabdominally or via a transgluteal or transrectal approach. Question: what is the principle of second-line rescue therapy in severe ulcerative colitis? Answer: if intravenous steroids fail after 3 to 5 days, consider infliximab or cyclosporin to avoid colectomy. This is a medical, not surgical, decision made in consultation with gastroenterology. Question: what is the single most important factor in achieving a good outcome in emergency surgery for inflammatory bowel disease? Answer: timing is the most important factor. Operating before the patient progresses to irreversible shock or perforation occurs is critical. The decision to operate should not be delayed once clear indications are present. Thank you for joining this podcast episode. We hope these questions and answers provide valuable guidance for the emergency surgical management of inflammatory bowel disease. If you enjoy the content, please like, share and subscribe. It's the Everything Surgery Podcast. Dissect the extraordinary.